Welcome. Today I'll be talking about clinical reasoning for physiotherapists who are undertaking practice via telemedicine. That is, remote consultation appointments via telephone and video calling software. Our objectives for this session are to briefly revise the models of clinical reasoning which are used in practice, and to discuss some research which highlights differences in how extended scope practitioners, or more commonly called now advanced practice physiotherapists, reason compared to non-ESP physiotherapists. Then we will look at how some of the complexities of advanced practice reasoning may be present in telemedicine. Finally, we will highlight some key ideas of how we can supplement our reasoning processes for telemedicine practice, and I will present a speculative new model of reasoning in telemedicine which can be discussed. So we may ask, what is clinical reasoning? It's defined by some as the thinking and decision-making processes used by physiotherapists in clinical practice. However, it is context dependent and is focused on guiding physiotherapists to make actions. It's involved at multiple levels, from using clinical data to make a diagnosis or to guide the changes one makes in a patient's management plan. It is also part of how we develop rapport and communicative relationships with our patients. Clinical reasoning assists us to build relationships which are both informed by clinical data, but also are integrated with the patient's lived experience. Clinical reasoning exists on a continuum, with a data-driven, analytical and strong scientific approach at one end, and the less easily defined processes of clinical intuition at the other. The most common form of reasoning used in medicine is hypothetico-deductive reasoning, or educated guessing plus testing. In this form of reasoning, data is collected from the referral and the subjective assessment in order for the physio to make a short list of potential hypotheses or differential diagnoses. These hypotheses are then used to predict what will happen in an experiment, or in other words, the objective assessment is used to negate or prove each hypothesis. Say, for example, you have a 22-year-old female patient who presents with an unstable knee after twisting injury playing football. She describes a gross swelling at the time and is struggling to run without the knee giving way. Your hypothesis list may include the potential for an ACL ligament injury. If so, you would predict that a Lockman's test is likely to be positive if your hypothesis is correct. Each hypothesis is then tested in this manner until you can better define the problem in question and come to a diagnosis. Pattern recognition is a model taken from cognitive psychology. It proposes that suitably experienced clinicians can recognise certain features of a patient's presentation almost instantly, allowing them to identify other relevant information. When working within their domain of speciality, clinicians can rely on their organisation and accessibility of stored clinical knowledge. They may use if-then statements. For example, if a patient presents with a long-standing history of pain, reports allodynia and describes fear-avoidant behaviour, then the clinician may be confident in a high probability of a peripheral or centrally sensitised nervous system component to the presentation. The ongoing assessment will then aim to refine the perception of this pattern for future use. The move from a previously established conception of the diagnosis from a set of specific findings towards a generalisation is known as forward reasoning, whereas in hypothetico-deductive reasoning, the clinician moves from a generalisation of multiple hypotheses towards a more specific conclusion, or backwards reasoning. Of course, although pattern recognition is faster and more efficient, it is difficult to use for less experienced clinicians or those working outside of their area of expertise. It is also open to confirmation bias, where a favourite pattern may be ill-defined and seen with every case, leading to misdiagnosis. As such, physiotherapists will often use both forms of reasoning dependent upon the context of the case. It is thought that humans are neurologically hardwired to use storytelling to make sense of experience and understand the needs and motives of ourselves and others. Narrative reasoning is an inductive cognitive strategy moving away from testing for cause and effect in diagnosis towards establishing insight into the patient's perspectives and personal story. It is the process of understanding the patient's experiences with illness and injury within the biosocial context of their beliefs, values, culture, and all aspects of their wider lives. This model is used by experts to develop a multidimensional knowledge base, which links assessment to function, demonstrates a caring attitude, and considers patients as individuals with unique life experiences. This form of reasoning is more likely to be applied in making shared decisions through close communication with our patients to guide their care, rather than when we are giving them a diagnosis. One study by Dr Neil Landridge explored the differences in clinical reasoning between extended scope practitioners and non-ESP physiotherapists when assessing patients with low back pain. The study had a two-stage design, starting with 3 focus groups of 6 participants each, 3 ESPs and 3 non-ESPs, all data from which was recorded and transcribed. This was followed by semi-structured interviews of 10 ESPs immediately after completing a low back pain patient assessment, where they were asked to reflect aloud on their reasoning in the session. A grounded theory approach was used to analyse the results. The main themes were developed to explain how ESP reasoning may differ from non-ESP staff, and we will examine whether these themes are likely more prevalent within telemedicine practice. The first theme is prior thinking, which entails the knowledge gained about the patient prior to the consultation. It comprises natural knowledge, understanding of biology and etiology, and clinical patterns known to the clinician from similar cases. However, the question to be posed is whether clinical patterns learned in traditional assessments carry over to the telemedicine environment. Do subtle signs taken in face-to-face communication transition to telephone or video, or are there alternate patterns to be observed that we don't know about yet? Theme 2 is concerned with the patient-therapist relationship and the development of confidence in the clinician. It involves the listening to the patient's story to understand them and build rapport. Providing an environment via telemedicine which is safe and secure, whilst being receptive to hearing the patient's concerns regarding remote communication, is important. However, this also shows the need to build a holistic profile of the patient prior to the consultation. Providing online methods of patients sharing their preferences, beliefs and expectations prior to the appointment would assist us to build this profile and may supplement remote care. Theme 3 is the most contentious of the ideas to consider for reasoning in the telemedicine environment and concerns formal testing. It involves the use of physical or non-physical tests to aid diagnosis and management, as well as diagnostic examinations to inform decision making. The ESP clinicians felt that the use of investigations created greater objectivity, moving clinicians away from using patterns of subjective symptoms towards biostructural diagnoses. It's pertinent to consider where diagnostic testing occurs alongside remote care pathways, and whether the assimilation of a patient profile could effectively inform appropriate diagnostic testing prior to a remote consultation. It also provides an opportunity for clinicians to evaluate their reliance on the use of some physical tests, which have poor diagnostic accuracy. The safety and accountability theme covers safe practice, vigilance, and medico-legal responsibility. The clinician's awareness of their professional liability, the clinical safety of the patient, and the clinician's perceived accountability are also included. The accountability felt by ESPs is considered an important part of their role, differing from non-ESPs, and a pressure not included in previous clinical reasoning models. The additional responsibility for the patient's safety is in part due to the complexity of the patients encountered, but also related to the ESP's role in appropriately diagnosing and directing their care. This increases anxiety and stress in even experienced staff. The use of telemedicine in clinical practice may be felt to similarly elevate the accountability of clinicians. The lack of confidence and competence in working remotely will enhance vigilance and make clinicians more risk-averse. Theme 5 encompasses all the external and internal influences on reasoning. External factors may include policy or trust directives, whilst internal factors may include the clinician's perception of themselves and how others view them. Generally, ESPs feel that such influences negatively impact their decision making and that clinicians have to justify their practice in light of such factors. The tasks undertaken by ESPs also places them under greater scrutiny, placing pressure on their reasoning process. The environmental shift to telemedicine provides both the external influence of a new model of care, which doesn't directly translate with traditional practice, but also the internal factors of causing clinicians to reflect on their competence in employing normal practice in a different way. Both of these changes can lead to the clinician to feel they are under greater scrutiny and need to justify themselves. The elevated anxiety may impact their reasoning. Defined as a subconscious process of thought, gut feeling is a physical reaction felt by a clinician linked to fear and concern. This intuition is central to the reasoning processes for ESPs, where they make judgments through clinical assumptions based on limited clinical data prior to the exam. They then use their experiential knowledge to inform their choice of tests to confirm their hunch. The degree of gut feeling influences different parts of the assessment, from the clinician's view of the patient to the degree of vigilance required for the specific case. However, ESPs find it uncomfortable to recognise its use, as it is a step change from more analytical approaches which provide more support when justifying their reasoning. Questions remain as to whether intuition based upon patterns identified in a telemedicine environment are reflective of those developed in clinical practice, whether they can be enhanced by having more data prior to the assessment, or whether they will develop over time. The final theme is time. Specifically, this concerns the time available to build a therapeutic relationship. Non-ESP staff reported having the ability to develop rapport with patients over multiple appointments, which is different to ESPs who typically saw the patient once. This is pertinent in telemedicine, especially when patients are being remotely monitored. It may suggest that the time spent when reviewing patients along their pathway should concentrate on engaging with the patient's story to enhance the therapeutic relationship. It may also suggest that data and time are available to build rapport prior to and within the first appointment. Taken together, Landridge's work highlights similarities in the traditional reasoning of ESPs and what is required when practicing via telemedicine. Safety and accountability and additional internal and external factors place all clinicians, irrespective of experience, at a high degree of scrutiny. Pattern recognition, honed over years of practice, may in some cases be less accurate. The physical gut feeling of intuiting a complex or dangerous case may be muddied by elevated vigilance with all cases due to the environment. A mix of pattern recognition, narrative and hypothetico-deductive reasoning is required, but perhaps in a different arrangement to traditional practice. Back in 1998, work was undertaken to examine clinical problem solving in the context of telemedicine. The research group wanted to verify to what extent the technological environment preserves characteristics of medical reasoning seen in traditional settings. Their contention was that clinicians should not take for granted that their traditional reasoning processes will carry over into telemedicine. The researchers developed what is called a semantic network of varied ontological levels. This is information which would include a clinician's observations, clinical signs and symptoms, theoretical knowledge of pathophysiology, diagnostic patterns, and wider global complexes which include multiple diagnoses. They also linked these ontological levels by their relations to each other, such as whether one implies another, whether one causes another, whether one is before or after another, or whether one is part of another. Needless to say, without examining the detail, this diagram illustrates their main conclusions. A. Problem solving in medicine is complex and multifaceted. B. Separate clinicians, demonstrated via the bold black lines, who use different methods of assessment will come to conclusions using different considerations of the same data. And C. Diagnoses may end up being very different depending upon the mechanism of assessment, experience and background of the clinician, and the methods of clinical reasoning they employ. The conclusions also advise that medical problem solving within telemedicine may require even experienced clinicians to employ backwards reasoning to come to the right conclusions. This showed greater diagnostic accuracy compared to relying on forward reasoning from pattern recognition. They also found that the semantic framework of reasoning was enhanced through having more data points, and suggests two approaches to elevate reasoning via telemedicine: collaborative reasoning and data-enhanced reasoning. Collaborative reasoning is a framework applied in the cognitive sciences and artificial intelligence research when developing intelligent systems. It consists of combining individual perceptions of a patient's problem to develop a global model of the problem. Each individual provides different components of the collaborative semantic framework, which alone may not solve the problem. Already part of our systems, we employ this approach in patient review sessions and the wash-up of integrated clinics. However, when applied for telemedicine, it may be worth considering its use earlier and more frequently as a cultural and system change to enhance the reasoning of all. A telemedicine environment should be a system of technology which goes beyond the provision of remote consultations. The collection of a patient's personal, subjective data can be assimilated alongside their preferences, expectations, and needs to develop a holistic profile of them as an individual. This may even include their previous experiences in physiotherapy to ensure they are treated as a returning patient in the future. This may also include exercise adherence data, which is already able to be collected via PhysioTrack. The development of an automated system of outcome measure collection and reporting would further enhance such profiles for both individuals and for the larger patient population. Using this data-enhanced approach, as clinicians we can facilitate pattern recognition and forward reasoning, which is deemed to be a more accurate form of problem solving for diagnosis. But what could that look like? This is a simplified model which illustrates one method of bolstering pre-contact information to enable data-driven reasoning. That's the blue box on the left side. The remote consultation can then be framed in the context of understanding more about your patient prior to assessment and takes into account the modified data which can be collected via telephone or video. It then shows how the transition from an early hypothesis can be defined over time using both continued remote monitoring and the collaborative meta-knowledge base of the wider team. Further, a culture change towards such a model reduces scrutiny on each individual, reduces anxiety and stress, and shares accountability. Of course, this is only one model in which collaborative and data-enhanced reasoning can be employed, and it is up to us to find one which works for us as individuals and as a team.